Good evening, colleagues. I think we have an important webinar today. This is going to be on clinical dilemmas in using novel oral anticoagulants. We have an expert in the field, Dr. Sanjay Kaur. He's professor of medicine at Cedar Sinai Medical Center, Los Angeles. He has extensive research experience and clinical experience in thrombosis and vascular biology, acute coronary syndromes. He has been part of many popular clinical trials. He is going to talk to us on an important issue today, that is the decision making in using newer oral anticoagulants. Let me start off with one practical issue, patients are of small build. Do you think that we need to consider lower dosages of NOACS in them?
Yeah, actually, none of the trials actually enrolled patients less than 50 kilos, and none of them enrolled patients greater than 120 kilos. But if you have somebody who's less than 50 kilos, then I err on the side of using a lower dose, but it has not proven to be, there's no proven efficacy for it. So in the weight range of 50 to 120, I do not adjust according to the body weight. The two criteria that you should adjust to is based on renal function and liver function. If you have severe liver impairment, then these drugs should not be used. And if you have severe renal function, ideally you should avoid these drugs, but if you have to, you can use apixaban and rivaroxaban safely. Warfarin would be my treatment of choice if you have a very low body weight individual.
Personally, what would be your choice among the available newer anticoagulants? Weighing the advantages and disadvantages.
For low body weight?
Among the newer anticoagulants, left to you, what would be your choice?
Personally, apixaban is one that is most commonly used in my practice. There have been no head-to-head trials comparing these NOACS, but apixaban data seems robust because there is not only a reduction in thrombotic endpoints, but there's clearly a safety advantage. There is no increased risk of GI bleeding, and so apixaban is the most popularly used one. Although I would argue the most effective NOAC is dabigatran 150 milligram. But because of the baggage of bleeding, people were reluctant to use dabigatran in the States. But my understanding is that because of cost issues, this is the reason why it's being used increasingly in India. Anti-TENA agents are a lot more expensive. Is that correct?
Dr. Kaul, very nice lecture. Just a quick one. If a patient develops a GI bleed, that to a major bleed on rivaroxaban, would you desist from using dabigatran or you go for apixaban, or what's the recommendation?
Well, you certainly can. You could. I mean, first you have to figure out what is the reason for the bleeding. If it is a lower GI bleeding, then I will not expose them to dabigatran. I would certainly try apixaban. But you can use any of those agents interchangeably. If it's an upper GI bleeding, I would have no hesitation in dabigatran. Or you may have to actually end up using warfarin depending on what the situation is. But I think you have to find out what the underlying etiology is.
There are two of my colleagues who are interested in knowing what would be the indication of newer oral anticoagulants in conditions like cerebral venous thrombosis?
Yeah, there are studies that are ongoing, but I at this point feel hesitant to recommend these agents. I don't know what the burden of thrombosis is in cerebral venous thrombosis. If it's huge, then I would be very reluctant to use these. As I mentioned, that when you have a large thrombus burden, these drugs are not very effective. That's why with mechanical valves and with rheumatic mitral stenosis, we usually don't recommend these drugs.
There is a question on usage of dabigatran with aspirin in atrial fibrillation. I think you already understood it. Probably would like to, re-emphasize on the point. Can we use dabigatran with aspirin in atrial fibrillation?
The recommendation right now is that if you're going to use dual therapy, you're better off using a P2Y12 inhibitor as the antiplatelet agent. And you can use clopidogrel and ticagrelor. Those are the only two agents that have been studied. In the RELY study, roughly about 8% of patients were on aspirin and a P2Y12 inhibitor. So there is clearly evidence, trial evidence, to suggest that you could certainly use dabigatran and aspirin together. But there's not been a study comparing dabigatran plus P2Y12 inhibitor versus dabigatran plus aspirin. But the dabigatran plus P2Y12 inhibitor trumps warfarin plus aspirin plus a P2Y12 inhibitor. So at this point, I would say yes, preference should be for a P2Y12 inhibitor. If you don't have P2Y12 inhibitor, you can certainly use aspirin with dabigatran.
There is another question. It's a clinical scenario rather. 55-year-old female, hypertensive and atrial fibrillation, mild left atrial enlargement. Should she be on oral anticoagulant or double antiplatelets are going to be sufficient?
Yeah, it's a good question. I mean, it depends on what her, the size of the atrium is. Sometimes it also depends on the diastolic function. It also depends on what the LV function is. And there are age-dependent thresholds based on whether they have hypertension, whether they have diabetes, or whether they have heart failure. For heart failure, my age threshold is lower than 65. But if it were diabetes, my age threshold would still be 65 and over as part of the CHA2DS2-VASc score. So it all depends. And remember, CHA2DS2-VASc score does not capture some of the important things that we utilize in our clinical practice, such as what is the size of the left atrium, whether there is presence of smoke in the left atrium, or whether there is any diastolic dysfunction, or what the LV ejection fraction is. It doesn't capture that. And so if this patient has large left atrium and has heart failure, then I would definitely consider anticoagulating her. If the patient does not have these, then CHA2DS2-VASc score is around 1 or 0. 1 because of diabetes, and that would, you can safely not use any anticoagulant, or you can just use aspirin alone if you have to.
And personally, my usage of NOACS is little limited. But whenever I use dabigatran, dabigatran giving rise to dyspeptic symptoms seems to be quite common in my practice. Dabigatran usage and dyspepsia.
Yes.
Yeah,
dabigatran dyspepsia is due to the tartrate salt, and a lot of physicians give their patients proton pump inhibitors or H2 antagonists, thinking that this may be an acid-related problem, and it's not. So I always advise them that you should probably give it with meals. That's a much better strategy than using a Nexium or Zantac because it's not going to reduce dyspepsia.
Administration along with food, does it make difference in reducing the dyspeptic symptoms?
You're talking about the exposure?
Dabigatran
The
along
bio,
with food.
yeah, the bioavailability will be somewhat reduced, but the patients will not feel the dyspepsia.
There seems to be a question, relevant to his specialty. How do we screen patients for detecting atrial fibrillation? People with hypertension, things like that.
Yeah, this is the big question that has plagued all these professional guideline societies. The United States Preventive Services Task Force, in its 2018 recommendations, recommended against the use of EKG for screening atrial fib patients, simply because there's not enough data to support whether it's very effective in capturing screening AFib, and what do you do once you have patients with a snapshot captured on the EKG. So the ACC/AHA guidelines also endorse the USPSTF guidelines. So at this point, screening for AFib is not recommended. But remember, we have the advent of these mobile devices, Apple Watches, and other devices which can actually monitor the rhythm. And there's been a lot of criticism against the use of those for making these treatment decisions about, screening for AFib and then treating them. So remember, the recommendation for treatment with NOACS to prevent stroke complication in AFib should be based on the underlying risk of stroke. It should not be based on whether it is paroxysmal or permanent or persistent. It should be based on the underlying risk of stroke. And as I mentioned, whenever the risk exceeds 2%, which is a risk score of 2 in men and 3 in women, then that would be the indication to start these patients on NOACS.
Yeah. So I have one question. I was going through the guidelines of the latest one, released 2-3 days back, 2019 update on the AFib guidelines, where they have mentioned very low GFR, below 15. You can use either warfarin or apixaban.
Right.
What is your comment about it?
Well, again, this is evidence derived from a pharmacokinetic studies in 8 patients with apixaban and 8 patients with rivaroxaban. And they observed that the drug exposure in these patients was similar to what you use with a higher dose of those drugs in patients with normal or moderately renal impaired patients. So this is not based on a large body of clinical trial, based on a very small number of patients that were studied in a pharmacokinetic, pharmacodynamic studies. So the FDA approved initially only apixaban, and the dosage was based on those 3 attributes that I talked about. If the age is less than 80 and the body weight is greater than 60, and then you can basically give 5 milligram dose. If it is age is greater than 80 and the body weight is less than 60, then you can use 2.5 milligram dose. And so following that FDA approval, the rivaroxaban studies were also done, again in the same limited number of patients, pharmacokinetic, pharmacodynamic. And so the FDA extended that label to rivaroxaban as well. But the guidelines are only focusing on warfarin and apixaban. But I'm just telling you that even rivaroxaban has that FDA. So I usually use apixaban. I have a lot of patients with end-stage renal disease, and I have had no issues with apixaban.
So, in the very elderly, beyond 80 years of age, do we have good, robust data on dabigatran, or what's your recommendation? How do you treat these very elderly patients?
Uh, there, over the last few years, I have had a lot of nonagenarians and octogenarians have tolerated apixaban, and rarely I have some patients on dabigatran. So I don't think age or frailty should be a contraindication to the use of these drugs. I would argue that these patients are at the highest risk of stroke, and therefore the absolute benefits are going to be much greater in these individuals. So I have, I would say 85-90% of my experience in the 80-90-year-old is with apixaban. And I don't see many problems with that. With dabigatran, I used to do that. But in the earlier days, 2012, 2013, if somebody was over the age of 85, I would be very careful in monitoring their renal function and their hepatic function before initiating dabigatran. But I feel more confident with apixaban in the elderly.
There's a question on 75 milligram of dabigatran dosage. What would be the occasion where such a dose would be useful?
Yeah, if somebody has severe renal insufficiency with a creatinine clearance of around 20, somewhere between 15 to 30, this is the situation where the FDA has approved 75 milligrams BID. And just a little trick, if you give 3 75 milligram dabigatran, it's the same exposure as 210 milligrams. So you can, if you didn't have 110 milligram dose and you have only 75 milligram, 3 will do the trick. The other situation where I will use 75 milligram is if somebody has undergoing a PCI and setting of ACS and has a high bleeding risk, then I would use 75 milligram dabigatran BID in that situation, because the bleeding risk is high and we don't have 110 milligram available here. So cost might be another reason, but I do not know whether the 75 milligram dose it costs less than 110 and 150. So those were the 2 or 3 scenarios where I would use 75 milligrams.
When you need to combine with certain other drugs which can interact with the molecules, what do you consider lower dose like 75 milligram in such circumstances?
Yes, there are situations where you could do it. Rifampin comes to mind. If somebody has tuberculosis and is on rifampin, you could certainly use that. We don't encounter scenarios like that in the U.S., but that's another scenario that you could consider in your practice in India. Yeah, I have seen that with. Yes, thank you for reminding me. I've seen that in people with HIV who are on triple antiretroviral therapies, and before the other drugs were available, that would be another scenario where 75 milligram BID dose was used in people with moderately impaired renal function.
Do you routinely recommend monitoring patients on NOACS? This is a question from one of my
I don't know what
colleagues.
you mean by monitoring. Monitoring what? Renal function, liver function? Is that what you mean?
What he means is probably the coagulation parameters.
No,
Coagulation time.
we don't do that. And as I said, we don't have any point of care assays that are approved in the United States. If I needed to, if I didn't know if the patient was taking dabigatran or anti-10A if the patient was scheduled for cardioversion, and I wanted to know whether the patient had been adherent on it. Maybe in that setting, I would get an APTT instead of getting a transesophageal echo. I'll just get an APTT to get an idea that at least the drug is on board. The patient is compliant with that. That's the only scenario where I would use it. I have used it maybe once or twice in the past few years, sent off an APTT before doing a DC cardioversion, but not routinely. In Europe and in Canada, you have the ability to do that because you have that assay available. What the guidelines, 2019 guidelines recommended that you monitor kidney and liver function at the time of initiating therapy and once per year after you have started it. I would err on the side of monitoring their renal function more frequently, depending on their age. If I have somebody over the age of 75, 80, I will probably monitor their renal function 2 or 3 times a year, not just once a year.
Maybe can you spare another 2-3 minutes with us?
Sure.
Yeah, thank you. There's a question on the duration of therapy with dabigatran after pulmonary embolism in a patient who was immobilized following fibular fracture.
Yeah, it's the same as we do with any DVT, EE. You treat them for 3 to 6 months. And if it is the first episode, then you just limit to 3 to 6 months. If it is recurrent, you have the option of treating for a prolonged period of time. Of all these NOACS that have been approved, the only one that was evaluated in DVT associated with cancer is edoxaban. But cancer-associated DVT, I feel more comfortable using low molecular weight heparins long term. I don't feel comfortable using NOACS.
Few of my colleagues are interested in knowing the most important drug-to-drug interactions with the NOACS.
I'm sorry, I did not hear you. Can you repeat that?
The important drug-to-drug interaction. Drug interactions with NOACS. Important ones.
Okay. When dabigatran was first approved, around that time, there was a drug called dronedarone, called Multac. That was also very popular. There was a lot of enthusiasm amongst the EP docs for using dronedarone instead of amiodarone. And there was a significant interaction of dabigatran with dronedarone. So there were a few cases that I got called in for were because of the dronedarone dabigatran interaction. So in India, I would say the INH, the anti-tuberculosis medication certainly would be a major cause of interaction. Rifampin. Antiretroviral agents in America would be a source. Antifungals. Some of the largest drug exposures seen with ketoconazole or the ketoconazole type of antifungals. So those are the things that I would be very careful about. Rifampin, anti-tuberculosis drugs. Verapamil I've seen also interact with dabigatran particularly. So amiodarone, dronedarone, and verapamil with dabigatran, and antiretroviral with anti-10A agents, and antifungals with all of the NOACS.
Switching gears, I'm going back to another indication like atrial flutter. In flutter, we traditionally say it equal to atrial fibrillation to decide on anticoagulation. My question only two. One is, do we have any robust data, or are we going on the presumption that most of the time flutter initiated by AFib? That is question number one.
Yeah.
Question number two is, what to do after flutter ablation? Whereas after AFib pulmonary isolation, we tend to continue antibiotic longer time. Whereas flutter is a little simple ablation, lasting relief, recurrence is low. Do you still ask us to give an indefinite period of anticoagulation after flutter ablation?
Yeah, the 2019 guideline recommendations has offered some insights into it. They basically say that atrial flutter should be treated like atrial fibrillation, and the need for anticoagulation should be determined by the risk of stroke. So you can use a CHA2DS2-VASc risk assessment to make that determination. And the need for long-term use of anticoagulants post atrial flutter intervention would also be dictated by what the CHA2DS2-VASc score is. If it is greater than 2 in men, then lifelong treatment with anticoagulation. If it is 0 or 1, then you can limit it to 4 weeks post atrial flutter intervention. You asked whether it is based on robust evidence. The answer is no. It's not based on robust evidence. It's based on expert opinion and limited data. So nowadays we have further elaboration of these guideline recommendations. They say it is class 2 or class 1 level C, which is a non-randomized expert opinion, and then they highlighted whether it is case report, CR, EO expert opinion, or LD limited data. But this belongs in the expert opinion and limited data category.
I think, it's time to thank you. It's a great job from your end. After listening to you, I think most of my colleagues do have more enthusiasm to use NOACS. Thank you very much and have a great weekend.